Lecture 2 will begin with a review of two preoperative topics. A. Indications and contraindications. B. Preoperative evaluation. We will start with the indications and contraindications for elective inguinal hernia repair. In this lecture, we will focus on indications and contraindications for inguinal hernia repair, patient selection for interns and junior doctors, ASA classification and surgical fitness which is relevant to this selection, and we will then emphasize which patients will require referral to higher-level facilities. Hernias don't go away on their own. They usually get bigger. Surgery is standard care, but for high-risk patients, you may suggest using a truss. However, these devices are often uncomfortable, cumbersome, and ineffective. The decision to perform surgery balances the natural history of the hernia against the risks of the operation itself. ASA physical status classification is used to assess a patient's health before anesthesia and surgery. Classes range from ASA-I to ASA-6, with higher numbers indicating greater medical risk. General practitioners at the health center should restrict elective inguinal hernia repair to ASA-1 and 2. If it is an emergency, surgery for ASA-3 under local block may be necessary. ASA-4 and 5 should be referred. Patient selection is about safety and knowing your limits. Ask yourself 3 questions. 1. Is this an emergency? E.g., incarcerated or strangulated? 2. Is the patient fit for surgery at my facility? Patients with severe COPD, ascites, or multiple comorbidities often need referral to a higher level of care. 3. Am I capable of repairing this specific hernia? Large, recurrent, or scrotal hernias are more complex. When in doubt, refer. Patient selection is important to get good results when cases are performed by interns. Start by selecting the easiest to repair. Indirect hernia with little or no dilation of the internal ring is the most common type of hernia in young adults. Difficult to repair, including femoral hernia, inguinoscrotal hernia, and recurrent inguinal hernia, should be avoided until experience is attained with the easier cases. Let's proceed from indications and contraindications to preoperative evaluation. Before proceeding, you should undertake an assessment of the patient's comorbidities, which are relevant to both surgical and anesthetic risk assessment. Comorbidities include HIV and local infection considerations. We will discuss preoperative laboratory investigations, antibiotic prophylaxis, surgical safety checklist, and informed consent principles. Comorbidities should be identified and managed. Diabetes should be controlled, anemia-corrected hypertension should be controlled, and patients with cardiac disease should be referred for consultation before surgery. Respiratory status should be assessed, and patients with COPD referred for consultation and surgery. Note that obesity increases operative difficulty, and smoking increases complications. Ask about bleeding disorders and the use of anticoagulants and nonsteroidal anti-inflammatories. Treat any active skin or systemic infection before surgery. HIV is not a contraindication unless the patient is immunocompromised. Routine labs are not required for elective hernia repair. Testing should be targeted to comorbidities and clinical risk. Assessment for anemia, infection, and platelet count with a CBC is sufficient for most patients. Obtain glucose or HbA1c in patients with diabetes or risk factors for diabetes. Obtain a coagulation profile if the patient is on anticoagulants, has liver disease, or is bleeding. A pregnancy test is required in women of childbearing age before surgery. Evidence suggests that antibiotic prophylaxis usually makes little or no difference in low-risk elective hernia repair, so selective rather than routine use is preferred. Avoid unnecessary antibiotics because they increase adverse effects and resistance. Use is more defensible in higher-risk patients, contaminated cases, longer operations, recurrent hernia, and immunosuppression. Using the World Health Organization surgical safety checklist improves outcomes. Before anesthesia, identity, site, consent, allergies, airway, blood loss, and confirm equipment is ready. Before incision, team introduction, correct patient/procedure/site, antibiotics, critical concerns before leaving the OR, counts, specimen labeling, equipment check, recovery plan. Whose responsibility is consent? Yours. Cannot be delegated. When discussing consent for a groin hernia repair, you must review the common risks: bleeding, infection, and recurrence. The specific, serious risks: injury to the spermatic cord, testicular atrophy, chronic groin pain, and nerve injury leading to numbness. The alternative to surgery includes watchful waiting. Document this conversation in writing. For each patient, you must ensure that hernia repair is indicated and that the cases selected will do well. A preoperative evaluation of comorbidities, targeted laboratory investigations, and informed consent are required.